or afternoon, wherever you may be joining us from today. Welcome to today's PC-PCC webinar entitled Change Agents in Action, Lessons Learned from Leading Primary Care Practice Facilitation Programs. This webinar is sponsored by the PC-PCC Outcomes and Evaluation Stakeholder Center. I'd like to provide a few PC-PCC announcements, and then I will introduce the faculty before we begin the presentation. First, I'd like to say that the Outcomes and Evaluation Center meets monthly for an open forum call. The next call is on June 27th at 1 p.m. Eastern. If you're interested in joining the center, please contact Tara Hacker at THACKER@PCPCC.net. June is Payment Reform Month at the PC-PCC, and they will be featuring this topic throughout PC-PCC communications, such as e-newsletters and new resources, and through speakers and webinars. The next PC-PCC National Briefing, which is a free registration, will be on June 27th at 11 a.m. Eastern. And there will be a reveal of the upcoming Stakeholder Center projects and activities on that briefing. It will also feature Dr. Kavita Patel of the Brookings Institution, who will lead a presentation about payment reform and its impact on physician payments. The next PC-PCC webinar is going to be on Friday, June 28th at noon Eastern. It's entitled In Search of Joy in Practice, Innovations from 23 High-Functioning Primary Care Practices. It's going to feature Christine and Tom Sinsky. And based on research published in the Annals of Family Medicine, this webinar will describe innovations that can increase physicians' work-life satisfaction, attract future physicians to the field, and improve the quality of patient care. And the last announcement I'd like to make, PC-PCC's annual fall conference will be on October 13th through the 15th this year in Bethesda, Maryland. Early bird registration ends August 30th. And this year, PCC will cover topics like health system integration, accountable care organizations, state and federal health initiatives, payment reform, education and training, safety net innovations, and new care delivery models. Now I'd like to introduce our three faculty for today's webinar. Dr. David Meyers is the Director of the Center for Primary Care at the Agency for Healthcare Research and Quality. David leads the agency's work in support of the primary care patient-centered medical home and serves on the U.S. Department of Health and Human Services teams charged with implementing the Affordable Care Act provisions related to prevention in primary care. Before joining AHRQ, he practiced full-scope family medicine, including maternity care, in a community health center in Washington, D.C., and he directed Georgetown University's primary care practice-based research network, Capricorn. Anne Lefebvre is the Associate Director of the North Carolina Area Health Education Centers Program. In this role, Anne acts as the Executive Director for the North Carolina Regional Extension Center for Health Information Technology for the state and oversees all HIT and clinical quality improvement consulting services from the 9 AHEC regional centers across the state. In addition to overseeing the daily operations of practice support services at North Carolina AHEC, Anne is also adjunct faculty in the Department of Family Medicine at UNC Chapel Hill and contracted faculty with the Institute for Healthcare Improvement. Jenney Samuelson is the Assistant Director at the Vermont Blueprint for Health, Department of Vermont Health Access, which consists of a team of 13 highly trained practice facilitators who assist over 100 adult, family, and pediatric primary care practices to implement continuous quality improvement. In addition, she oversees the statewide implementation of the Blueprint community-based self-management programs, including 6 evidence-based programs. Before joining Blueprint, Ms. Samuelson administered diverse community and statewide public health programs, including leading a 4-county health careers workforce development program, quality improvement with health systems to support tobacco cessation in primary care practices, and directing the state of Vermont's lead poisoning prevention program. Please note that there will be time at the end of the presentation for questions, so please submit any questions that you have in writing with the drop-down box that you see on the right hand of your screen, and we will address them towards the end of the presentation. And with that, I would like to hand it over to David.
Well, thanks so much, Angela, and thank you all who are on the phone with us today for joining. It's a real treat to be with you. Special thanks to the Primary Care Collaborative, the Patient-Centered Primary Care Collaborative, for inviting us at AHRQ and our colleagues from around the country to present to you some of our work. Now, you can tell by the title of today's presentation that I work for the federal government, because only a Fed would write a title that long. So I apologize for that, but thank you for joining us anyway. And recognizing that I am with the federal government, I'd love to tell you a little bit about the Agency for Healthcare Research and Quality, one of the smaller parts of the Department of Health and Human Services, but one with a huge mission. We think of our work here at AHRQ as helping care for the healthcare system so that the healthcare system is there to care for you and all Americans. And in thinking about how to do that work, as a health delivery system research agency, and research and quality are in our name, we think about how to generate new knowledge about the healthcare system and how it improves quality, how to translate that knowledge, that new evidence knowledge into evidence, and finally, how to take evidence and make it usable for the people on the front lines improving the quality of care. So it's a three-step process. And today we're going to be talking about some of the work we've been doing on that last step, taking evidence and implementing it into practice. How do we help the folks delivering care do it better? So with that, I can get the slides. There we go. So the goal of today's talk is to take you on the journey that AHRQ has been on about thinking about how we can help primary care transform. And what we're going to do is give you an overview of practice facilitation as one idea, one model that's out there for helping implement the patient-centered medical home and make it a reality. And we're going to highlight a specific tool from AHRQ and then go on to talk about how that's actually this tool and the people who actually inspired it, what they're doing in real practice, and what we've learned from them about how to do this. And finally, to make it real, we're going to turn it over to our colleagues from North Carolina and Vermont, who are two of the exemplars and leading edge thinkers and doers, implementers in this work, so you can hear it from them. And then, as Angela said, we'll have time for questions and a lot of dialogue. We'd love to hear from you about, is this something you think you can do? Do you have ideas of what else is needed to make this possible? And certainly to give you the time to ask the people who are actually doing this work about their experiences. So within AHRQ's mission about improving the healthcare system, and when we think about quality here at AHRQ, we think about better care, better experience, both for the people using the healthcare system, but also for the people who make up the healthcare system, the physicians, nurses, physician assistants, and many other healthcare professionals who are committed to the patients they serve. And then also better value. And we believe that revitalizing America's primary care system is foundational to achieving this idea of a high quality, high safe, high reliable healthcare system for all America. In thinking about, well, how do we revitalize America's primary care healthcare system, AHRQ has really embraced the model of the patient-centered medical home, one that is built on the fundamentals of primary care, that is supported by both structures and processes that are necessary to deliver this type of care. And we've also been very cognizant of the idea that to do this, we need to think about providing sustainable resources, which includes payment reform, but also health IT systems, and as we're going to talk about today, a system for improving and continually improving the quality of care provided. Just like the PCC, AHRQ has a definition of the medical home. I hope this is familiar to many of you. We see it built on 5 pillars of primary care, but we also recognize it is not a place, but it's a process of delivering care. It's a model of delivering care that starts with the patient in the center, delivers comprehensive primary care that meets the majority of needs of the patients that the practices serve. The care needs to be coordinated and accessible. And we do think about that in terms of both linguistically and then the hours and many different domains of accessibility. And finally, that the primary care system of the future that is really going to deliver the triple aims of healthcare to the full healthcare system has to have a systematic way of improving quality and safety. As I mentioned before, we also are doing work to ensure that the PCMHs of the future are supported or undergirded by both health IT systems, workforce and workforce training, as well as payment reform so that they can be both successful and sustainable. So in thinking about this idea, though, that fifth pillar of a continuous quality improvement infrastructure, AHRQ recently published 2 papers on our websites, and after this call you'll be able to download these slides, and both of these are links. I'll show you later where to find the website, but these 2 papers talk about our vision for developing a quality improvement infrastructure for the primary care system and the components thereof. And I'd just like to highlight a few pieces of that right now. 4 key tools from all of the work we've done around the country with researchers and with implementers emerge as what is necessary for quality improvement. It starts with data feedback and benchmarking. We don't know where we are, we don't know where we're going without these, and we don't understand how we're getting there. Practice facilitation or coaching recognizes the needs that most folks who are primary care professionals did that for the purposes of caring for patients and don't necessarily have all of the skills in management and quality improvement that they might like to have in order to do their jobs, and that bringing that in from the outside is an important strategy. Academic detailing and expert consultation recognizes that none of us know everything that we want to know and that there's much we can learn from outside experts. And we can talk later, if you'd like, a little bit about the difference between the model of practice facilitation or coaching and the use of expert consultation. And finally, an idea that is quite old in primary care, which is that we learn best in our communities when we learn from each other. So the development of learning collaboratives, which our colleagues over at the Health Resources Services Administration really pioneered with the Institute for Quality Improvement and the FQHC movement. But together, these are 4 powerful tools for quality improvement. And as we learned more about these, we recognize that practice facilitation, which we'll talk about for the rest of the call today, really takes advantage and pulls together the other 3. It really can be the glue for these. So what is practice facilitation? It is not exactly one thing, but it's a way to support primary care or other medical practices in ongoing efforts to improve quality. It is provided by either individuals or teams of individuals who themselves are specially trained on the range of QI practice and practice improvement techniques and processes. And it is not something that is delivered with the idea that everything is done from the outside. This is not doing for practices. It is teaching practices. It is building their capacity for future quality improvement, at the same time supporting them for in their current quality improvement efforts. We started seeing practice facilitation used as a model for quality improvement, especially in primary care, starting as early as 2008, very soon after the concept of the patient-centered medical home started gaining traction. And as we watched this, we saw that the people who were doing this were often doing exciting things, but not spending a lot of their time teaching others, and certainly not spending a lot of their time writing things for research journals. And so it was taking a while for this knowledge that was developing on the ground to spread. And so what we did is we went out and found these folks and brought them together and invited them to share. We interviewed them and brought them together into a learning collaborative and allowed them to share their hard-earned lessons without them having to spend a lot of time writing it up. We did the writing for them and together distilled their wisdom through an iterative process into a how-to guide about practice facilitation. The first iteration of the guide, however, was not designed for the practice facilitator herself, for the person who's actually doing practice facilitation. It was aimed at organizations such as AHECs, primary care associations, health plans, health systems, who might be interested in using practice facilitation, delivering practice facilitation to a group of practices to improve quality. In addition to developing the guide, when that was released, we also developed a series of webinars to go through the parts of the guide and a national newsletter and users group for people involved in this. And here's the key website you're going to look for any of the materials I talk about today are available at pcmh.arc.gov. And then on the left-hand navigation side, you can see a tab for practice facilitation. So everything I talk about today is going to be available there. So there's the guide, and what's inside it? Well, based on the experience of the experts, we broke this down into a series of simple how-to steps, and we went through the thought process and the knowledge and some actual techniques and tools for people who wanted to organize practice facilitation programs. And here you can see how it is organized. There's a background and some evidence about practice facilitation, an overview about creating the home or the center, the organization, that is what an organization needs to know about starting a practice facilitation program, a chapter on funding. One of our webinars was specifically devoted to that because sustainability is not only important to the primary care practices, it's going to be important to the people who support them. Thinking about the approach to practice facilitation, which involves if you don't know what you're trying to change, you won't know how successful you are. And so starting from the beginning by identifying your goals. The second half of the book talks about hiring and training practice facilitators, supporting them and supervising them, and then given that this is AHRQ and our interest in research and evaluation and data, a good section on evaluation of yourself, the quality and outcomes of your program. We had a lot of success when we first released this, a number of people, several hundred. We were actually expecting that maybe 25 to 50 organizations would have interest. And we were thrilled to see how much interest there was in the guide. But one of the things folks said to us very quickly is, this is great, but can you show me a picture of what it really looks like when it's happening? We did the webinars as a quick answer for doing that, and we brought together some of the leading primary care facilitation programs to help us run those webinars. And then we also spent some time with them. We interviewed them, we visited with them, and we produced detailed case studies of 4 national leaders, 2 of which we're going to hear from today. As part of that, these books are 10 to 12 pages each that go through what are they really doing, how are they organizing, and it maps well to the how-to guide, but it really gives you a vision of what a practice facilitation can look like and can do. So together, we see these as complementary set. The how-to guide gives you the steps to get there, and the case studies provide a vision of where you may be trying to go. The programs themselves are rather diverse in how they are organized. They include state-based, mostly in their thinking, but some homes are in academic centers, other in AHEC programs, others in the safety net and PCAs, and Vermont's, as we'll hear from later today, a real statewide initiative that involves state government as well as public health. In addition to putting out the guides, and now we're getting into the meat of today's program, we highlighted from what we learned from the 4 of them, their shared lessons, what they wanted to teach people who were thinking about engaging in practice facilitation. And so I'm going to highlight for you a few of those right now, but then leave it to Anne and Jenney to give you really the personalized view of these facts. And the first thing we learned over and over consistently, both with these 4 leaders, but also from others we've worked with, is that facilitation is about relationship building. If you don't put in the time, you don't give the resources, and don't think about those human-to-human interactions, the power of practice facilitation does not emerge. The programs also told us that the coach, him or herself alone, will do some, but is not enough to really change a practice. And that combining it with those other tools we mentioned earlier, data and feedback, academic detailing, or content experts, as well as peer-to-peer learning, which does not always mean a national meeting with hundreds of people. In Oklahoma, that can mean taking 3 doctors and nurse practitioners out to breakfast once a month at a coffee shop in town to say, how's it going, what are you learning, what are your challenges, and letting them solve their problems together. And that this idea of bringing people together to learn is not only true for the practices who are receiving facilitation, but it's very important, and it's a powerful tool to bring your facilitators together. And we heard from Jenney's bio earlier, she's got 13 of them, that bringing them together to learn, to problem solve, to support each other, to develop new materials is a very powerful technique. So in the same way we're doing practice facilitation and quality improvement in practices, we need to be using those same techniques ourselves to improve. I'm sorry this isn't a hot link, but if you go to the website pcmh.arc.gov and you look for these 4 guides to the 4 different programs under our practice facilitation section, you'll also find a single, I think it's about 8 pages, that distills these lessons. And I gave you the highlights just a moment ago, but then it goes on to some more detailed things on lessons on administrative infrastructure, on how to design the program, on how you train your facilitators, and how you assess effectiveness. So again, very much mirroring the chapters of the how-to guide. These are practical lessons learned from people on the ground. If you're interested in learning more, I recommend this guide to you. With that, I'm glad to stop the bureaucratic talk here from AHRQ and introduce you again to 2 wonderful folks who have done really impressive work helping primary care in their states improve. And first we'll hear from Anne, and then hopefully later we'll be joined by Jenney, and she'll be able to tell you about Vermont. But with that, Anne, I'd love to turn it over to you.
Great. Thank you so much, David. That was a great setup. So as was said previously, I'm an Associate Director of the North Carolina AHEC program. As we talk with people from other states, I thought it might be first important to talk about the North Carolina AHEC program in itself so that everyone understands that our AHEC may be a little bit unique. This is where we've chosen in our state to house this type of program, and that may work with other AHECs across the country, and it may not. The North Carolina AHEC program receives both state and federal funds, but a large amount of our funding to support our residency programs and things like that are from the North Carolina state funds. We currently are a very large program in the state of North Carolina. We employ over 1,500 people across the state of North Carolina. The North Carolina AHEC program itself runs residency programs and have graduated over 3,000 physicians out of our own residency programs within the state, which is important here because, as David was talking, a lot of this work is based on relationships and trust. And if a physician is going to let an outside person come in and help to facilitate change in their organization, trust is very important. And many of our physicians in our state came up through and did their training with an AHEC residency program. Many people in our state, as they go through the 4 medical schools in North Carolina, may use our AHEC system for student housing. So we provide student housing at each one of our 9 area health education centers and provide student housing for over 10,000 student months a year. And this is not just within the School of Medicine, but it's also nursing and pharmacy and dental and allied health. And so we actually can come into, we have opportunity to engage with students at a very young age in their health career and really shaping their understanding of how they use and interact with AHEC as they grow in their professional careers. The North Carolina AHEC program is the largest provider of continuing education activities in our state. Typically, we serve over 200,000 health professionals a year in providing them credits towards their licensure and certification within their own health profession. Other interesting programs that are not unique to the North Carolina AHEC, but AHECs across the country work on, are building understandings of health careers. So we work with, each year the North Carolina AHEC works with between 35,000 and 40,000 middle school and high school students across the state, introducing them to health careers, especially in disparate neighborhoods, to really talk with them and make sure that everyone understands that when we're talking healthcare, it's not only nurses and doctors, but there's health information technology and lab techs and radiology techs and all kinds of different avenues and opportunities in healthcare. And the other thing we do as an AHEC is we really focus on workforce diversity, making sure that we can influence and really establish a diverse workforce, which then can really make an impact on health equity. In addition to all of these services, in 2006, the North Carolina AHEC program, along with our partners at Community Care of North Carolina and our professional organizations in the state, along with the Division of Public Health, took on a program called Improving Performance in Practice. It was funded by the American Board of Medical Specialties, really looking at, will private primary care practices allow an external resource to come in and help them learn how to build the capacity to improve care? And that's really where this started, and the North Carolina AHEC program took this on. In 2006, we started to pilot this along with the other pilot that was going on in the country at the time in Colorado, and we started to pilot this in North Carolina. We worked with 16 practices at the time. Those 16 practices worked in this area you can see here on improving clinical outcomes in diabetes and asthma care. For a 12-month period, we focused on these 16 practices. Our biggest question at first was, would they let me in the door? Will they truly allow me? For anyone who's worked in academic detailing in the pharmacy industry, you know that the big question is, can you get back? Meaning, can you get past the lobby? And that was one of our questions, was, would they see us as a similar sales type entity, or would they truly allow us to come in and coach their practice in change? And we learned very quickly that they were very open to that, and it was exciting because it was a very new delivery model at that time. So within our first year in working on this, we found that we had improvement in every measure over all 16 practices to some extent, and we were very excited, and it was really gained momentum in our state, and we were allowed to expand. In 2009, the HITECH Act, as part of the stimulus, came into play, and the governor of North Carolina asked the North Carolina AHEC program, with our experience in coaching, to really take on being the regional extension center for health information technology. That allowed us to really build out our services to really provide a full spectrum of practice facilitation to the primary care base across North Carolina. And so we grew that with the federal funding that we received from the Office of the National Coordinator. We grew from working in about, at the time, in 2009, we had grown to about 120 practices, really focusing on improving clinical outcomes, with about 9 coaches. And we grew that to our peak of working with 1,104 practices with about 52 coaches across the state. Now, we worked with those practices in this, what I would call a continuum of care. And so I often refer to this as our buffet of services, meaning if they were a paper-based practice, we would help them move to an electronic health record. If they were already on an electronic health record, the first thing we wanted to do is make sure that they could meet the meaningful use incentives, and that they were really using their EHR with all the bells and whistles that it came with, and really achieving that incentive money that was available to them. Everybody in our program then expected each practice to understand that meaningful use was really just the start of the work that they were doing. It was a very foundational piece of what we wanted them to build in their practice. And so we encouraged practices to move further in this continuum, or buffet, to really working on improved clinical outcomes, and then using all of these techniques to really make sure that they were transforming into this higher concept of a patient-centered medical home. So from 2009 to currently, what we did was, originally, as we were focused on improving clinical outcomes, we had QI consultants or QI coaches in the practices. These were people who may or may not have had clinical backgrounds. We had some masters in nursing. We had some masters in public health or masters in health administration working with us as coaches. We found very quickly as we worked in practices that we really needed EHR expertise, that, as David was saying earlier, in order to really engage in improvement, you have to have that data, and getting that data out of those systems is really no small task, and it can become quickly overwhelming to the practices that we were working with, especially as we really sought out to work with independent primary care practices that really needed that extra support in really obtaining that data. What we learned early on was that we had to help with the EHR piece, because otherwise the improvement work that we really wanted, this improvement work to focus on transforming the delivery systems within this practice, to really look at the clinical interactions and really hitting those pieces that we felt would make the highest impact on a patient's health outcomes. But what happened without the EHR support and being able to really get good data, what happened we found was practices would focus on improving their ability to obtain data instead of improving their systems within their practice. And so the more we could get in there and help with getting the data that they needed to do this, it allowed them to more quickly move on to really improving their delivery systems and eventually the health outcomes in their patient population. So when the opportunity to become a regional extension center came to us, what we did was build out and say, yes, we need this QI expertise, but we also need to build our skill sets in systems, in both delivery systems, but also in technology systems, in electronic health records, in data harvesting software, and those types of things. And in doing that, we also needed some people on our team with a deep technical specialty, and we needed a combination of skills that we could bring into the practice. The skill sets that we were bringing into the practice often could not be within one human being, and most probably importantly is these skills that we bring into these practices still at this point have not been developed in an academic curriculum. So it's not that someone comes out with a degreed program in this area. And so what we did was build these skills in these teams of experts around the state. So the blue arrows on this diagram are our offices, or our AHEC regional centers across the state. These centers are all to serve the communities, and you can see the regions that they're split up in. The team of expertise that we have is located at each one of these centers. We have teams anywhere from the size of 3 to the size of 7 across the state, depending on how many practices they serve in their region. And then what we did was build these teams of experts so that they would have a go-to person within their team, so that you felt that you had that supported regional expertise. But in addition to that, we cross-trained everybody so that I may be in a practice and my expertise is truly in improvement sciences and working with practices on improving their systems and their processes. And if a practice had, a deeper technical question, it may be something that I learned from working with my colleagues in another practice, or it may be something that I say to this practice, I need to get, my team member, John, to come in and work with you on looking at that specific item in your EHR. When can we set it up for him to come in? And so it was a way for us to really build the confidence within our staff, and we were able to cross-train pretty readily, and I think we've been able to really enhance everyone's skill set, including my own, and what I've learned from these personnel coming on. It's really been an exciting time. So the way that this looks in our program, and this is not unique to us, I think this is really what's happening out there, is a typical workflow, and a very basic workflow in a practice on the left-hand side here is basically that, a paper chart is placed at the vital station to say that a patient is ready to come back from the lobby. They're all checked in, they're ready to go. The patient then is called to the vital station because that chart is there. The height, weight, blood pressure is taken and recorded. The patient is then taken from there to the exam room. The chart is placed on the door to signal to the practitioner that the patient is ready to be seen. So this is a very common practice within a primary care office. Well, if you're focusing on technology and if you're focusing on moving that practice to an electronic health record, it's pretty cut and dry. It's pretty clear what needs to be done. You have some paper triggers in this process that need to be addressed with an electronic health record, and how will these paper triggers, such as the chart is on the door, that chart holds the patient's name. How will that provider know what that patient's name is if that chart is not on the door? How do we know that the patient is sitting in the room? EHRs do this very easily, but again, each EHR system may do it a little differently with color changes and room numbers and those types of things, but it's a paper trigger that we embed in the EHR. Then the next thing that's needed is to look at your templates to make sure that your workflow matches the templates that you need in your EHR, those types of things. This is what's being done in regional extension centers across the country, helping practices understand truly how to move from a paper system to a good, strong electronic health record system. So those are pretty basic. And what we did then is layer these so that our folks who are helping practices move to an electronic health record helps practices start to think in a quality improvement mindset, such as, well, this is great and this is your system, but the reality of it is you have one vital station and 5 exam rooms. And at 8 o'clock in the morning, when you have 5 patients scheduled at 8 o'clock in the morning, how are you getting them through your vital station in a way that's not creating a backup or frustration? Because at this point, this is where we're taking blood pressures. Blood pressures are data. They're data that we're using in our systems to monitor care. They're also data that we're using in a way to judge whether this patient needs medication or medication changes or lifestyle changes. So it's data, and it's really important. If a patient is scheduled at 8 o'clock and we can't get them even to the vital station until 8:10, how much are we contributing to their increased blood pressure? How often do we room patients without taking vitals because the vital station is backed up? Maybe we've moved cuffs and scales into the room to compensate for that. How are they calibrated? Are they the same? Are they manual in the room and automated in the vital station? So just getting practices to start thinking about these things in a way that's just outside of the basic technology, but really looking at how do they want to make some of these changes? They don't have to make these changes when they're putting an EHR in. We'll support them after hitting meaningful use, but these are some really important questions because then you get them down, and what we try to do is make them data hungry. So we start to ask questions of, well, how many blood pressures do you miss? If you'll room a patient by skipping the vitals, hoping you'll come back to the vital station at the end, how many blood pressures are we missing? What is the difference in calibrations, and have we tested it? And so what we really want to build out is making them data hungry, really making them start to think, how do they want to use this electronic health record as a data system or a relational database? So when after a practice achieves meaningful use and they want to continue on with us with improving clinical outcomes, we've built out our change package with them, which is part of our key driver diagram. So Dr. Darren DeWalt and others have helped us develop this key driver diagram to really target our targeted outcomes are on the left-hand side of the screen. Our main key drivers are in the center part of the screen, and then on the right-hand side in our key driver diagram are some of the interventions that we'll work with. And these are all very high-level interventions. Each one of these interventions that we could do could have anywhere from 10, 20, 30 PDSA cycles that go on to test these things to make sure that we're targeting these key drivers. But we've really come down in the last couple of years to feel that these 4 key drivers, which you'll notice are very closely tied to the care model from the McCall Institute, this is not anything that we've developed over the time. This is something that we've learned from others. And as we keep continuing to test whether these key drivers work or not, they come through every time. And if we focus on these areas, we really do see an improvement in the health outcomes of the patients. So this is just an example of taking that practice past meaningful use and helping them, again, get data hungry, really push to see their electronic health record systems, give them the data that they need so that they really can embrace the model for improvement, so that they can learn how to use data as storytelling in their practice. We try to help engage them in that team-based care so that everyone in their practice is really looking for these results in their health outcomes, and so that they can understand that if you're asked to call an extra 10 patients a week to try to get them in here, what is your part in improving patient's care.
So then the phone number is?
Oh, I think someone's breaking through. I don't know if they want to mute for a minute. So we did, in North Carolina, we did have some additional incentives that we were able to offer in this program. The Blue Cross Blue Shield of North Carolina has what's called a Blue Quality Provider Program. That is an incentive for independent network providers in our state to really reach certain goals, including patient-centered medical home and quality improvement activities in their program, including also there's some incentive in there to work with the North Carolina AHEC program, and it's actually a reimbursement enhancement program. So that's very nice, and it's really taken a bump up with PCMH in our state. The other thing that we offer is because the North Carolina AHEC program, we go out as educators, which is nice. Again, it helps to build that trust and relationship in the practice. So as educators, all of our coaches are able to work with the providers in the practices, and we're accredited to provide maintenance of certification Part 4 for all medical specialties, as well as the performance improvement CME of up to 20 hours of Category 1 CME per year for the providers as well. We do offer peer networking. We offer each one of our 9 AHEC centers has conference venue facilities, and we do offer them to come together and really work together 3 to 4 times a year. We offer them to come together in the evenings and share what they're doing. We do offer them access to practice-based research networks and other national leaders in quality improvement and some other methodologies that we have access to, and I think that's a piece of this is allowing community-based providers to have some of this access to things that they may miss from being involved in their residency program and those types of things. And the other thing is we have AHEC digital library services that we can bring out so that even a rural-based physician can have the same access to research and literature that you would have right here on the campus at UNC Chapel Hill. So those are just some of the things that we provide to the programs. This is really, I'll be honest, this is my creation here, and this is my, looking at our program and seeing what we feel that the future needs of practices are. I think that the needs of things like system implementation, things like moving from a paper-based practice to an EHR, maybe upgrading, significant upgrades to EHR, those technical systems implementations are going to greatly reduce. They're already great. The need for those is greatly reducing. Fortunately, and that's because most primary care practices are really coming up on electronic health records, which is really exciting. But what I see going forward in 2014, 2015, and beyond is really this uptake in learning how, or increasingly learning how, continually learning how to improve your systems. And whether that's systems of care, systems of delivery in your practice, or it's also improving your technology systems too with the coming on of ICD-10, meaningful use stages 2 and 3, PCMH initiatives as they roll out in the states. They seem to be different from one state to another, but also PCMH in itself, I expect the next set of standards to be a little higher up on the notches. And then any other payer incentive programs, government payment programs such as PQRS and those types of things, but also what ACOs are going to start to expect out of primary care practices and what they can generate, not just from their EHRs, but truly from their team-based care and their delivery systems. And then, of course, we're moving into, or maybe even have already arrived, into tiered payment systems and payer profiling. And I think learning how to improve your local systems so that you can see how that matches with the algorithms that are applied by providers and things like, or by payers, becomes increasingly important in the next couple of years. So this slide is truly just my guess as to where things are going. So I guess I'm going to hand it over to Jenney.
You should be all set. Jenney, are you trying to speak?
Okay. And I've got control. Okay.
Jenney?
Yep, I'm here.
Oh, perfect. Awesome.
So are we ready? Let's go ahead to the next slide. So I'm coming from the Blueprint for Health here in Vermont, and there are several. I'm going to give you initially a brief overview of the overall blueprint so that you have a context of which our facilitation program is working in. For Vermont, we have, as part of the blueprint, advanced primary care practices or primary care medical homes. We embed within those medical homes community health teams and community-based self-management programs. And to support them, we have our multi-insurer payment reform, a health information infrastructure, and evaluation and reporting system that helps feed data. We also have, and what our facilitation program is a component of, is our learning health systems activities. I'm going to go briefly through a little bit about some of the infrastructure that's behind it, and then I'll talk about our facilitation program. So what we ask the primary care practices who are involved with the Blueprint for Health in order to have their involvement is that they develop multidisciplinary quality improvement teams and that they work on continuous quality improvement in their practices. And we support that continuous quality improvement with our practice facilitators. As part of that, to receive the payment reforms, they also have to become recognized at least at a level 1 for NCQA, for the MCQA patient-centered medical home recognition. As an addition to that, we embed within the practice care coordination through our community health team, and we ask that the practices, as well as the health and human services providers in the local area, are involved in the community health team development. And we support that with the health information technology infrastructure. In Vermont, remember, we're a small state. There are only about 600,000 people in the entire state, and a total of about 180 primary care practices. To date, in terms of their patient-centered medical home recognition, we have had 106 practices recognized as of the beginning of this year, and probably another 10 or 15 on top of that. And we're working with a total of about 130 practices in Vermont with our practice facilitators. The community health teams that we have that we're embedding are multidisciplinary teams. They're designed and developed locally. We have 14 health service areas around the state, and the practices are affiliated generally with a hospital in that health service area, and we have an entity who's doing project management overall. They are integrated into the practice, and oftentimes the practices and the health and human services providers in the local area get to choose who is hired by that community health team. And although there are 14 different areas that are making those choices, the majority of the areas are first choosing nurse care coordination and social work care coordination, and then beyond that they're choosing health coaching and nutrition and asthma type supports. So often people ask where the community health team sits because there's a lot of targeted services. It doesn't take away the need for those targeted services, but it generally is the care coordination that happens between and/or the population management that's happening within the context of the practices. To help coordinate that level of care, we have the health information infrastructure in Vermont. The practices are connected to the health information exchange, and then information is fed from the health information exchange into DocSite. Practices that are paper-based practices still can access this as a resource. They can access the registry in a web-based fashion, as do the community health teams, where they put in information. And the goal is to create an integrated health record so that with the consent of the patient, the care teams can see the information from the specialty providers, the community health team, and the primary care practices. To support that, people ask, well, how do you get the primary care practices involved? It's not just the community health team. They also receive a per patient per month payment, and that per patient per month payment is scaled based on their NCQA recognition and score. It comes from our 5 major insurers that we have in Vermont, the 2 public insurers, Medicaid, Medicare, and then our 3 private insurers in Vermont. And the amount of money that's for the community health team is actually a pooled resource that comes straight from the insurers, but it goes to one entity in the community who helps to disseminate them out to the practices. That way you can share one dietitian across 5 practices versus having 5 practices hire a quarter of a person. So this is a diagram that begins to bring in where we're going in terms of our practice facilitation model. We begin by looking at the established guidelines and measures that are out there in clinical practice. We we feed that information into developing a core data dictionary for HIT, and then that spins around to collecting process and outcome measures that we feed back to our practices. And from that, we have our practice facilitators who are going in and doing coaching within the practices, and also feeds into our collaboratives. Again, the payment, that information that comes out of those outcome measures also helps to inform our payment reforms that we have here in Vermont. So what does our practice facilitation program look like? We have 13 practice facilitators. Each of them are serving between 8 and 10 practices. They come from diverse backgrounds. Our key important thing that we found is that hiring for the skills that they have versus their professional backgrounds was more important. They have a long-term relationship with the practices. They're focused on the interests of the practice first. So one of the first things that they ask the practice is, what is it that you feel that you want to improve for your patient care and for your providers in the practice? They provide quality improvement support, and they assist with the patient-centered medical home recognition process. Our practice facilitators also are working within the context of a team. That team includes the project manager in the local area who's marshaling up the resources like the community health team to embed in the practice, but also what our regional extension center e-health specialists are working directly with the practice facilitators, helping to support the implementation of EMRs. In Vermont, we have about 85% of our practices are on electronic medical records. And then once they're on, the e-health specialists and the practice facilitators are working on connecting them to the health information exchange. The types of support that they provide are consultation to the practices. They do in-practice facilitation. And then we also have group learning activities. So within the state, we've begun to do collaboratives. And when I talk about that, it's a systematic set of measures that each of the practices agrees to collect. And then group learning opportunities around the collection of the measures and what processes people have put in place to improve those measures. We've worked on them. Currently, we have an asthma collaborative going on, cancer collaborative, and we also have one for opioid addiction. And with that particular collaborative, we're also embedding a nurse care coordinator and a social work care coordinator into the practices who are providing Suboxone. We also provide ongoing training on things like motivational interviewing and other types of skills that the practices have identified as really key and important. Shared decision-making, self-management support. So one of the things that's really critical, people will change what they're measured on. And so the practices, the facilitators are working actively in the practices to help them collect the process measures for improvement. They're using their electronic health records. They're also using the centralized clinical registry, which is fed through the health information exchange. We're able, through our all payers claims database, to provide practice profiles back to the practices so that they can see how they're doing on HEDIS measures and on utilization and cost measures. That's newer to us, and we're just getting that data out to the practices. They're also provided with their MCQA scores and opportunities for improvement. And then we administer the CAPS through the blueprint for practices who are interested in that. So we're providing back patient experience information. All of that information, the facilitators are working in the practices on taking that information and actually helping to translate that into identification of areas for improvement. Where are we going next? I've described the fact that we have been working in the practices on quality improvement, recognition as patient-centered medical homes, but our facilitators are also beginning to work with specialty providers. People who are providing specialty addiction providers has been our first take as we've begun to convene collaboratives related to the prescribing of Suboxone for opioid addiction. We also are beginning to work with some of our HIV providers who are the medical homes for their HIV, and it's likely that we will start to look at working with long-term care. What we found is that the opportunities to go in and assist them with quality improvement in the practice and the methodology for collecting data, identifying improvement is really of support to the practice and isn't all that different between the primary care practices that we've worked with and the specialty practices that we're hedging into.
Okay, great. Thank you so much to all of our faculty for this great presentation about practice facilitation. I just wanted to make a note that the slides from today's webinar will be archived on the PCPCC website within 1 to 2 days. So stay tuned for that if you wanted to get a copy of the slides. And now we have time for questions from the audience. So we have a few that were turned in. If you do have any questions that you want to address to the faculty now for the remaining, I think we have 30 minutes left, please do so. The first question is for all the presenters. What do you consider the most appropriate ratio of practice facilitator to the number of practices?
In Vermont, we've seen a dose response curve and what we have found, originally we thought it was going to be 10 to 15 based on consultation with other practice facilitation programs. And really, as we began to get to above 12, that even our most effective practice facilitators were not able to achieve the same outcomes. So we've found that between 8 and 10 practice facilitators, 8 and 10 practices per facilitator is advantageous.
So here in North Carolina, I will tell you that this seems to be like the $60,000 question. And I think it depends on the work. So because our program is a little diverse and we have some practices that are just working on EHR implementation and not yet moving to the other pieces, it depends a little bit on the caseload that the person is carrying. I used to think that the caseload could be a little bit higher. We were shooting for 20 at one point in our program. And I think when you're doing some of the basic moving towards electronic health record and meaningful use, that's possible. As you're getting into practices that are really engaged with transformation of their practices and looking at the different delivery systems and those types of things, I do think that caseload is less than 20. We're still shooting for the 15 range. We may need to look at what other programs like Vermont and things like that are doing. The balance of it, and this depends on how your program is run, but the balance of it is keeping enough of a caseload going so that if a practice runs into a distraction, because all of this, the practices, at least in North Carolina, are all volunteer. We serve at their pleasure. If a practice says, I need to pause for a month for residency turnover, or I need to pause for 2 months for this, we need to have enough of a caseload for that person so that we're, can pick up in another area. So I think that's the rub. But I agree. I think for the real work on targeting transformation in practices is 15 or less.
And this is David here at AHRQ. In some of our work surveying folks, one of the things we've seen is that different facilitation programs have different intensities of the support they give practices. Some of them are very high intense for shorter periods of time and then go into a less intense maintenance phase. Others sort of have a basic level that they maintain for a longer period of time. But we've heard, I think the examples you've given are exactly what we've heard from other folks. The smallest ones tend to be in 5-ish per facilitator. Those tend to be during very intense periods. We've not seen any that really surpass 20, and the majority tend to go in the 8 to 10 range.
Great, thank you so much. And just something that came up earlier, I know we've talked about the AHEC program. Anne, perhaps you could just give a brief overview of what the AHEC program is, AHEC, for those on the webinar that may not know. And then someone had asked, do you know of any other AHEC programs in the U.S. that are doing the same thing as you all in North Carolina?
Yeah, so the AHEC program really comes out of the HRSA office for the federal funding, and it's not necessarily in every state across the country, but it's in a lot of states. I don't know what the recent number is, but majority of states have some sort of an AHEC program. It stands for Area Health Education Centers, and it's typically tied to academic institutions within your state. As to so each state chooses how to run their AHEC program differently, and the North Carolina AHEC program tends to be very different from most states' AHEC programs. So we recognize that right off the top, that we really, the majority of the funding for our AHEC program comes from outside of HRSA and other resources, the largest one being the state of North Carolina. So we're very fortunate to have that additional funding. The practice support services, at this point, as far as I know, that I think the North Carolina AHEC program may be the only one providing the actual practice facilitation services, but I do think that there's other AHECs that are looking to provide additional services to primary care practices looking to do this work. And so there may be different models out there, but I don't know of any that are specifically doing a coaching or facilitation model.
Great, thank you. And also another AHEC question, does the program have resources available that anyone can access in regards to facilitation?
In North Carolina, it is focused at this point on primary care, but it is anyone in primary care. So I refer to our services as, our smallest practice is a family nurse practitioner and an admin in a truck that serves in the Walmart parking lot within their community. They're a free clinic up on an electronic health record. And up to, we serve academic medical centers, our federally qualified health centers, private practices, solo, up to our highest number is 92 physicians within one private practice. And really anybody in primary care in our state is available to these services. At this point, we're still fortunate enough to have enough patchwork quilt of funding to provide our services free of charge to the practices that are working with us. And so at this point, it's only primary care, but we are looking to start offering, neighborhood type services in the future.
And are your facilitation tools posted online for others to use, or is it just specifically for those in your program?
Well, to be honest with you, we really don't develop. I think our model, our delivery methods, and our training are specifically for our own facilitators. But as far as the tools that we use, we really haven't developed any tools. There's plenty of tools out there, and so we have really made it kind of our job to make sure that we look out there first for tools and resources, and we really have not. We might have tweaked some tools here and there, but we very heavily rely on our colleagues across the country for tool development and things like that, because we feel that many of the tools out there for this type of work are well developed and we enjoy using them.
Great. And of course, as David had mentioned earlier, there is AHRQ's how-to guide that's available on the AHRQ website as well for anyone to access, and has a lot of great resources and lessons learned available as well. There are several questions about the role of the practice facilitator. First is, someone had asked if there are any practice facilitator job descriptions that are available and that folks can get access to.
In North Carolina, I'm happy to make ours available. Like I said, we really kind of have 3 different skill sets that we're looking for, and then we can combine those into any one of the job descriptions. But we really look for particular skill sets with a background in quality and systems improvement. We look for skill sets in systems implementation and practice redesign around technology, and then we do have another skill set in job description that we're looking for with some deeper technical skills, such as maybe programming and mapping and interfacing and those types of things. And so those are the 3 skill sets we look for, and we do have job descriptions with those, but we may combine job descriptions depending on what the team needs.
And this is David at AHRQ. On page 111 of the how-to guide are links to 4, or actually 3 different sets of job descriptions for practice facilitation folks, as well as a sample protocol for interviewing. So that's a resource that's available as well.
That's great. Thank you. Do facilitators lead the multidisciplinary QI teams, or does the clinic manager? And then just as a follow-up question to put two in one, about how long do practice facilitators work with practices in terms of time frame, particularly for practices who have already met meaningful use?
So in Vermont, it really depends on the skills and ability of the practice. We are always looking for a champion in the practice, and it doesn't have to be the practice manager. Often it's not the practice manager who will head up and lead the multidisciplinary teams. If we find when we walk into a practice that they don't yet have they've never met as a group, they don't have an emerging trusted leader in the practice that may not be the official leader or the authorized leader of the practice, then we will go ahead and our practice facilitators will start off by leading the group at the beginning of the process. So it really depends on the actual place that the practice is at. We have decided to continuously work with the practices on an ongoing basis. We have yet to find a practice that doesn't have a goal associated with quality improvement and the transformation in care, such as embedding panel management or following guidelines-based care or doing self-management support in their primary care practices. But what we have found is that there's a key role in the practice facilitator working with the practice to maintain the gains that they've had. So continuing to prompt them to collect the data that they have for surveillance to make sure that the changes that they've already made are continue to be sustained. That said, in Vermont, the practice facilitators, similar to what was mentioned before, may work more intensely with a practice during a period of time, meeting weekly or every other week at the start. But as they become more independent, they may taper that off to meeting with them once a month or meeting with them in a more group-oriented way, depending on the types of projects that the practice is working at and the skill level of the practice at that time.
Great, thank you. Anne or David, did you want to add to that?
In North Carolina, I think that we have a very similar model. I mean, it really depends on the practice. I would say that it takes more than 12 and less than 24 months to do this. At least that's what we're finding for the outcomes improvement. You know, really getting to meaningful use is kind of low bar and all that, and that's it's a little more cut and dry. When you get past that and really are looking to then, you know, really build the capacity internally to, you know, improve and continue to improve, like Jenney was saying, it really moves at the pace of the practice, sometimes at the passion of the practice, or maybe what their incentives are and where those, you know, whether they're internal motivators or external motivators, and what's driving the process.
Angela, on the first half of the question about who runs the practice facilitation team, while there are many models out there, most of the work that we've seen is focused on bringing this team as an external group. And so it wouldn't be, so while, and all of them agree there needs to be a practice champion and a real link between the practice facilitation team and the practice, and that over time the goal is to transfer more and more skills and then more and more responsibility to the practices themselves, so this becomes self-sustaining. Most of the programs have said that some form of maintenance is usually helpful, that the primary care practice gets back to its regular rut if you don't give it some maintenance and some booster shots of facilitation, and that the team tends to be run by a professional from outside the practice. There will be a quality improvement team possibly in the practice as well, often led by that key champion, but that the practice facilitation team, and so I'm curious from Anne, she described their team structure with the QI coach and the technical assistance coach and a third player as well. Is there, it sounded like there in North Carolina, and different people led different teams for each practice? Is that right, that you were all cross-trained?
Yeah, and I think most heavily maybe 2 years ago as we were really into EHR implementation, we definitely would have some handoffs so that this person, once the EHR was implemented, they met meaningful use, we may hand that off to a quality improvement coach while this person goes and implements another EHR in another practice. But, you know, within the last 2 years, we've really cross-trained all of our individuals. So now we may be able to maintain, and that person who just helped that practice meet meaningful use can then go on and facilitate that quality improvement, and that's really what we've tried to achieve with our program, and it's pretty exciting to see it coming. I think we're similar to what Jenney was saying in that, especially in the beginning, we may be the facilitators of the meeting. I think our ultimate goal is to build the capacity in that practice so that we basically work our way out of it, and they're not relying on us to facilitate their meetings and those types of things. But it's nice that we're a resource that's always available. So even if they build this capacity, but then, you know, have key personnel turnover or those types of things, we can go back in and help them quickly come back up rather than losing their whole program.
I wanted to add something else about the boosters, because I totally agree with you. For us, for some of the practices who started off more advanced or who and had a good orientation to quality improvement, and who like to spend time learning from their peers in terms of that what we call our learning health system, as we get to that point with some of the practices, involving them in the collaboratives, and then following up, having the practice facilitators' role and responsibility around the collaboratives. For example, the asthma collaboratives, where they're really looking at the implementation of asthma action plans, assessment of severity, assessment of control. That the quality improvement takes that focus, and that becomes their booster versus having the facilitator in that practice every week or every other week having to lead the teams. And that's where a lot of our practices evolve to after they've implemented an EMR, after they've achieved meaningful use, after they've done NCQA, and they're really on that path towards maintenance or towards looking through continuous NCQA recognition.
Great additions. Thank you.
Yes, thank you very much. And then another question, have any of you observed any differences in facilitation between pediatric and adult practices?
I haven't noticed a difference in facilitation. I mean, there's definitely differences in those practices, but I don't think. I think, and this comes out in the practice facilitation manual at AHRQ. Is I think the key attribute in a good coach or practice facilitator is truly their ability to be flexible in their approach. And so I myself have coached hundreds of practices while training throughout our program, and I have not noticed any key differences or needs that develop from one specialty to another. But I will tell you that there are some attributes of practices that require me to be flexible, where one practice may want a formal type meeting, another practice may want a hallway type meeting. And I don't think that they necessarily go by specialty.
I would agree with Anne. In Vermont, we actually had the opportunity to have our Child Health Improvement Program provide us with a pediatric-specific facilitator. And though she understands the conditions that they have, she understands the way to work on self-management in a pediatric population differently than some of our other facilitators. We actually have gone back to a model where it's more geographic or regional, and a facilitator from a geographic region would facilitate both the internal medicine, family medicine, and pediatric practices. But it is nice to have someone on staff who can help with some of that knowledge about what are the measures for pediatrics that you would want to have, what are some of the guidelines, where would you find them for pediatrics for a well child exam, for example. And so I would agree with Anne that it's not different by specialty, but there is different knowledge that people grow into when they begin to work in the pediatric practices, and it is nice to have at least one person who understands that world.
Great, thank you both. And then we had a couple of questions surrounding assessment of practices. Do any of you integrate an overall strategic planning session or assessment of the practice for overall business and clinical strategy first before doing the more topic-focused work? Another question, similar question came in asking what assessment tools or processes you use as you enter a practice.
This is David. I'm going to jump in here. This was one of the hottest topics among the experts that we brought together in developing the guide, and I was remiss in not putting out a thank you to all of them, and I hope some of them may even be on the phone today, but we heard Anne was one of them. At the beginning of the guide, you can see the diversity of folks, and it's really their work we're building on here. But in the guide, we included a lot about this, and they all were consistent in the need to, before you go rushing in and trying to change a practice, that you have to build that relationship. And part of that is explaining who you are and what you can and can't do, as also assessing their readiness for change, their knowledge base, what their preferences and priorities are. And in the resource section of the how-to guide, we have some samples of different kinds of practice assessments that different facilitation programs have used. But I'd love to hear specifics from our experts on the phone today.
Yeah, so in North Carolina, our practice coaches use what we call the CADIS, or we've developed the Key Driver Implementation Scale. So we assess each practice monthly. The coach assesses each practice monthly on their movement through our key driver diagram, and then we also include assessment of leadership and engagement with the practice. And so it's just a way to kind of assess where the practice is and how they're progressing through the program. And it gives us another feedback mechanism other than just the outcomes or, the clinical data that we're getting from the practice. As far as the, upfront talk, my work with my colleagues at Health Teamworks in Colorado, they kind of do this thing called the big call or the big talk with practices. And I think, I'll be honest, I think they're better at it than we are at this point. We definitely meet with the practices up front. If there's a part of our program that we're continually looking at and trying to improve, it's probably that initial contracting piece. And by contracting, I don't necessarily mean just a legal contract, but truly just setting expectations. And I find that to be probably the hardest part, because to build rapport, you can't be too rigid about that. And to work with truly diverse practices, including, rural, solo, or, some of these primary care practices that are truly struggling at this point, you really can't be too rigid on things, but your expectations for them have to be high enough so that, they get to, have some accomplishments in it. So while we do that, and I think that it's important, I think that we are always struggling to continually improve that in our program.
I concur with Anne. We've used a couple of different assessments. We used the Health Teamworks assessment from Colorado. We've used the 5 Ps assessments in clinical microsystems. And then our facilitators here have developed an assessment when they begin to work on NCQA recognition with a practice of where they are at with each of the intents of the NCQA standards. We have found in Vermont, our legislature said we will work with any willing practice. Some of the practices are more or less willing to complete the tools that I've just indicated, and the practice facilitator may pick or choose pieces of those tools to use with a practice based on their overall level of engagement. And if we feel like they're going to bolt right off, we might scale back on some of those tools before moving forward. We've also worked really closely with our REC, which isn't completely a part of the blueprint. It runs through the Vermont Information Technology Leaders, and one of the things that we recognize is that weakness. And part of it is really assessing the leadership's commitment and the culture of the organization before you go in, because we found that is one of the biggest barriers to being able to move forward, and it's one of the hardest things to assess.
Great, thank you. And sort of on the other side of that, Yes?
I'm sorry, and this is David again. I also want to
yes,
let
please.
folks know, because another part of the question was about the business case. I think there of working with practices before you jump into a quality project. You help them think about their strategic vision and maybe even their operations. And that absolutely is something we've heard loud and clear from folks, that it's hard for some primary care practices who are running really, really fast to even have the space to think about change and improvement, and that sometimes helping them get their business practices in order is a great first step that they find value in, they're appreciative of, and then as a result, they have some extra space, sometimes even resources, to devote to continuing to partner with you on quality improvement. Some of that work is available at AHRQ on a set of materials designed for working with safety net practices, where this is incredibly important. They're often working on the thinnest of margins. And so we have a guide for working with primary care safety net practices that starts with how to help them get their business case in order, and that is tied into how to use practice facilitation to help them do that. The ultimate goal of that whole suite of tools, however, is to get them engaged in implementing a chronic care model, which is clearly very similar and overlaps very well with a PCMH transformation. So if folks are interested in that, they can visit the AHRQ website as well. And it's called the Safety Net Transformation Toolkit.
Great, thank you. And then another question came in wondering how practice facilitators are evaluated. If any of you have insights to share on that.
So this is a key but tricky question, because we still struggle with this in our program. We have tried different things over the years, and I don't think we've gotten it right yet. So we really don't use any of our methods at this point to work entirely to hold the accountability of the coach. The challenge here is in the evaluation component, and we've just published this in some of our work that we've seen, is that just because a practice isn't improving in their health outcomes doesn't mean that they're not doing significant work, and they may actually be doing foundation building that may pay off 8 or 10 months from now. And so it becomes and this is why we use our key driver implementation scale to allow the coaches to really explain what they're doing with this practice, to really talk about what they're doing. The other thing that's challenging in this is the work of coaching and facilitating a practice. If you look to evaluate a coach on outcomes alone at work, it won't work. If you look to evaluate a coach on like a professional consulting relationship and whether that practice is happy with them, sometimes it takes tough love to get some of this work done, and sometimes the practice may not be, all enthused about what we're having to ask them to do. And so it's a challenge to really assess this. It's something we're continuing to work with, but that is one of the reasons why we try to assess the work in the practices with something that's, not necessarily tied right to their clinical data, because you don't always see the work there right away.
Great, thank you very much. And then we'll take one more question, and this will be for Jenney. For your work in Vermont, what factors went into selecting the disease states and behavioral modification area of focus and getting consensus among stakeholders?
So we don't have specific disease states that we ask the practices to work on. What we have done is to take a look at the practices who are able to choose 3 important conditions. Initially, we started by saying all in our pilot with 10 practices, you will work on hypertension, diabetes, and asthma. And the feedback from the practices was, well, in our practice, what we're really interested in working on is X, and so you're not getting as much out of us on diabetes, hypertension, asthma, because we're not passionate about it. So we've moved to having the practices select 3 important conditions initially to work on. Those are based on what the practice's desires are. And then we take the public health priorities that we have here in the state of Vermont, and we take the practice's level of interest, and from that we identify what topics we're going to work on related to the group learning experiences. Over the next year, it is likely that for the group learning experiences, based on the practice's interest, we will probably work on depression, we'll probably work on group collaborative on tobacco, we have one in the works for diabetes, we have one in the works for hypertension. And so that's a long way of saying we base it on the practice's interests and on the public health needs, but we don't require any one practice to take up a specific topic.
Okay, great. Thank you. All right, well, I think we have reached the end of our time together. Thank you all very much for your participation today, and we hope to see you on future PC-PCC webinars and national briefings. Thanks, and have a great rest of your day.